The modifiable risk factors in terms of aneurysms include things like smoking, alcohol use, hypertension, especially if it's uncontrolled or untreated. Non-modifiable risk factors include the female gender, prior history of subarachnoid hemorrhage, and family history. So ruptured aneurysms. So there is about anywhere from a 30 to 40% all-cause mortality related to ruptured aneurysms. And of the remaining survivors, probably up to 60% or more of them are probably functionally dependent afterwards. And so, it's a pretty significant hit to a patient and to their family. And a lot of these times, these patients tend to be younger, so they're in their 50s or 60s predominantly. Initial examination at the time of presentation after rupture tends to be generally a good predictor for what their outcome will be like. We have things like the Hunt-Hess scale, the Glasgow-Coma scale, the World Federation of Neurosurgery, and the Fisher scale to help with that. The main concern with ruptured aneurysms in the short term is rebleed or rehemorrhage from the same aneurysm. It's thought to be highest in the first 24 hours, and then these are some of the commonly quoted numbers afterwards. So about a 25% risk of rebleed in the first 2 weeks, 50% in the first 2 months, and then afterwards, if you don't treat the aneurysm, that same aneurysm has roughly probably a 2 to 3% rate of rupture a year afterwards. And the main issue with these ruptured aneurysms is that as you get into post-bleed day, 3 to 14, as is commonly quoted, you start entering into the vasospasm risk window. And so probably angiographically or on some form of imaging, up to 50% of patients have some form of vasospasm. Whether that's clinically significant is a smaller proportion. But all-cause mortality and morbidity associated with vasospasm is up to about 35% of patients. So we're talking about delayed cerebral ischemia, significant edema, and even potentially death. And so what you wind up with these ruptured aneurysms is the re-rupture risk from a hemorrhagic standpoint, and then your complications related to vasospasm risk, which is more of an ischemic insult. And so it makes it easy then why you want to treat the aneurysm after it ruptures. You want to treat it so you can secure it, so you can allow your triple H therapy and things like hemodilution, permissive hypertension, and hypervolemia to take course so that you can avoid the secondary insults from that. There's a lot of, traditionally I think within 24 hours in most places is pretty standard of care in the time frame that you want to treat a ruptured aneurysm. I think that's pretty standard. I think there's been some studies recently. I think some of the guys from Buffalo have talked about, ultra or hyperacute treatment of aneurysm, so on post-bleed day 0, and whether or not that portends a better outcome. And I think that's it's an interesting idea that still sort of remains to be fleshed out. And the other reason why you want to treat these aneurysms sooner than later after they rupture is that if you wind up in a situation where they're 10 days out from their bleed and then finally found to have an aneurysm, you have a lot of significant vasospasm you have to contend with in the course of trying to treat an aneurysm, which brings its own set of joys and pains with it. Basically, summary: ruptured aneurysms, treat them as soon as you can after they rupture, basically secure the aneurysm so that you can minimize their rebleeding risk, and then also as you get them into the longer course of their hospital stay, treat their vasospasm and things like that with your general tools. So unruptured aneurysms. So natural history of these aneurysms, so pre-ISUIA or ISUA, was estimated to be probably somewhere to 1 to 3% per year for aneurysms larger than 1 centimeter or 10 millimeters. The ISUA study came out basically kind of in 2 different phases. One was in '98 and one was in 2003. Following that, there was another study that was published in the New England Journal of Medicine, which was the Japanese cohort, or UCAS. There's one that I didn't list here, which was the Finnish study, which was published by Juvela, and then Phases, which is kind of a large cohort study that put together the Juvela, the Finnish study, the Japanese study, and also other large-scale studies to look to see if they could create a point-based system to help predict which aneurysms were at higher risk and basically give an estimate of rupture risk per year for unruptured aneurysms. And when you talk about unruptured aneurysms, you're really talking about the balance point between what is the risk of rupture for this aneurysm and, to some degree, what is the treatment risk. And your risk of rupture are sort of estimated, best case scenarios based on the available data from ISUA, from Phases, from UCAS, and things like that. And these aren't perfect studies by any sense of the imagination, okay? There's a lot of selection bias, there's a lot of crossover treatment bias, and things like that, and that all sort of factors into it. And so as we go through the data, you'll sort of see some of that. So this was initially what came out in 1998, which is the retrospective cohort, and it divided patients into group 1, which are patients who had never had a subarachnoid hemorrhage in the past, and then group 2, which are patients who had a history of subarachnoid hemorrhage but not of the same aneurysm that they were following. And what you can see here is that their sort of predicted rates of rupture are really, really low. You're talking about the cutoff was basically less than 10 millimeters, greater than 10 millimeters, or greater than 25 millimeters. And the numbers here per annum are less than 1%, about 1%, and then greater than that. What they did note was that increasing size did correlate with an increasing risk of rupture, which makes sense. And then also posterior circulation, which included the basilar tip, the posterior cerebral, the VB junction, and the PCOM in this situation. So fast forward to 2003, and this is more data has been collected, and again the same division basically into group 1, patients with no subarachnoid hemorrhage history, and group 2, which is a history of subarachnoid hemorrhage from a different aneurysm. And this is 5-year cumulative rupture rate, and so if you actually look at it per year, basically these are what the numbers come out to be. So higher than what they had initially thought in 1998, but still fairly low. And interestingly enough, posterior circulation is defined in this study included PCOM. So basilar tips, VB junction, PCA, and PCOM all get sort of cohorted together as the posterior circulation. And then if you look at the data, though, it would make it seem as though anything less than 7 millimeters, an MCA, any sort of an ICA, aneurysm, ACOM, things like that, essentially you have what would appear to be minimal or no risk from that standpoint. As you get to increasing aneurysm size, what they found is that the rates of aneurysm rupture between group 1 and group 2 were the same, and that's why you're only given data as a cohort. And sort of the same thing, basically. Predictors of rupture included increased aneurysm size and then posterior circulation in this situation. So the unruptured cerebral aneurysm study of Japan came out in the New England Journal of Medicine in 2012, and this was a very large-scale study. Had, I think, initially over 3,000 patients, and I think the patients that they wound up following that added to this final data set was somewhere around 1,500 or so, maybe a little less than that. And what was nice about this study was that they actually divided these aneurysms into varying locations. So instead of just saying, ACA, MCA, ICA is one big group, they said they've delineated basically the MCA, ACOM itself, ICA, PCOM, basilar tip, SCA, and then everything else. And their data actually present, there's not a laser pointer, I guess, on this. You can see that their data would indicate that there are varying risks depending on location. So, an MCA versus an ACOM versus an ICA terminus is not the same. And more importantly, specifically if you look at ACOMs, PCOMs, somewhere around that, 5, 6, 7, 9, your rate of rupture per year jumps significantly, okay? And this is something that we didn't see previously in the ICUA data, and that probably has some significance and makes sense. I feel like the majority of ruptured ACOM aneurysms we see tend to be on the smaller size. They're generally not these big ones that are greater than a centimeter. Limitations of the study is that we are not actually told how long the follow-up was for these patients, and it's a very homogeneous study, which is it's all Japanese patients. Mm-hmm. But their delineation here basically is somewhere between the 5, 6 to the 7, 9. There's a jump basically across most of these different aneurysm locations. The other thing that they looked at were additional factors associated with rupture of aneurysms. And the things that they found was, obviously increasing size of the aneurysm mattered, but also whether or not the aneurysm had a daughter sac. Things like that. And then also predominantly the ACOM and the PCOM location seem to have the higher risk as well. Which is what we talk about here. And then compared to ISHUA, basically, in the initial ISHUA study, ACOMs, MCA, it's essentially anterior circulation had minimal risk as far as they were concerned. And there was, I think probably because of the way that PCOMs were grouped into the posterior circulation aneurysm had a higher risk of rupture in ISHUA, but that didn't bore out to be the case here in the UCAS study. And then the ethnic demographics. So I think over 85 or 90% of the patients in the ISHUA study were predominantly white, whereas the study is almost entirely Japanese. And then we have phases, which basically took the UCAS study, ISHUA, a couple of other studies, and also the Javella study, which was a large Finnish study, and sort of pulled everything together to see if we could create a point-based system to assign a 5-year absolute risk of rupture, essentially. And you get points based on if you're Northern European, non-Finnish, Japanese, Finnish, if you have hypertension, age, the size of the aneurysm, and whether you've had a history of prior subarachnoid hemorrhage from another aneurysm, and then the location of the aneurysm itself. And assign points based to this. Both UCAS, the ISHUA, and phases, there's easy calculators you can find online. I think there's one website that aggregates them all together, and so you just sort of click through it. It's a nice tool to have in clinic to, before you go to see the patient, to sort of, ascertain whether there's some of their relative risks and things like that. And depending on where you're at, in the patient, sometimes that's helpful information, sometimes it's not so helpful information. And so we talked basically about what is the rupture risk for a previously unruptured aneurysm. And so the second half of this scale basically is talking about what is the treatment risk. And so one of the hard things I think, especially for patients to understand, is that when you talk about observing or treating a unruptured aneurysm, you're talking cumulatively per year an additive risk, basically, that this aneurysm will rupture. And so obviously the younger you are, the longer that time frame is. And so that number can add up, to a significant thing, but it may be something like 40 years in the future. Treatment risk is something that's a little bit more upfront. It's a hit that you take initially with any decision for treatment, and I think sometimes it's harder for patients to sort of be able to balance that in their minds. You're talking about a 40, over the course of 40 years, you've got whatever, a 30% risk of this aneurysm will rupture, or a 10% risk with any procedure that you may have a significant complication or morbidity, mortality associated with that. This is data initially from ISHUA, so these numbers are probably definitely out of date to some degree. But the long and the short of it is that if you aggregate, either open surgery or endovascular together, probably somewhere around a 10% risk, maybe a 5 to 10% risk of having a significant complication related to treatment. Okay, and that could be something as, in the worst case scenario, death, paralysis, hemiparesis, major stroke, or something as insignificant as groin complication, wound and things like that. And so that's what you're trying to balance, basically. So what is the additive risk of rupture over a patient's lifetime? What is the treatment risk? And one of the things that we don't talk about very much is that, especially with both of these categories of either open surgery or endovascular, one of the treatment risks, aside from just having a debilitating neurologic deficit, is what is the risk of recanalization or incomplete obliteration, right? And that's something that's a little bit more complicated, and that's something that in general we think with clipping it's probably more robust. With coiling, there's a higher rate of recanalization or need for retreatment in the future, and so how does that factor into it as well? So the clinical quandary basically is that the majority of unruptured aneurysms are less than a centimeter. Majority of even ruptured aneurysms that cause subarachnoid hemorrhage are also probably less than a centimeter. Growth is not always a predictor of rupture. There's been aneurysms, I'm sure that you guys have seen as well, that have been followed for years, have appeared stable, and then one day the patient comes in and that thing's burst. Or other patients that we've had aneurysms that maybe are growing in for reasons they don't want to treat or whatever, that continue to not cause them hemorrhage as a problem. And then the other question is, are these natural history studies really accurate? All right, there's a lot of selection bias in who stays in these observation arms. There's a lot of patients who wind up getting pulled out of studies because they get treated, and so you can make the argument that at worst that these studies probably underestimate what the actual rate of rupture is for patients, and that's something to know going into it as well. So this is from a paper that was published, I think Dr. Monteith was the editor for this journal back in 2015, the Scientific World Journal, and I think it's from, I believe it's some people from Jefferson, basically, and they sort of wanted to create an easy sort of, graphic of how do you want to treat unruptured aneurysms. And their delineation basically was patients who are over or under 60. So the ISUA data and other data, is pretty clear that older age portends, a greater interventional risk in terms of morbidity morbidity and mortality, and then aneurysm size. And their cutoff here was 7. Depending on who you talk to, anywhere from 4 to 6 is probably also reasonable to consider treatment depending on the patient's age. And the main things basically are if someone is, less than, 60 years old with an aneurysm that's, greater than 6 or 7, you probably, definitely consider treating this patient. If it's less than that, depending on what their additional risk factors are, such as a family history of, aneurysmal subarachnoid hemorrhage, bad hypertension, if the aneurysm looks ugly with, irregular walls or excrescences on its on the wall itself, you may consider treating it earlier. And then patients greater than 60, this becomes a little bit harder. Less than 7, probably you're okay to not treat, depending on their other non-modifiable risk factors. If you're over 7 millimeters, again, probably consider treatment for these patients, knowing that they will have a longer recovery course and probably a higher associated risk with any intervention, whether that's coiling or clipping. And so general thoughts. So stratification of unruptured aneurysms basically by location, size, high-risk features like daughter sex and things like that, along with the patient's age, their prior history, their family history, and other risk factors are what you have to do when you consider whether or not unruptured aneurysms need to be treated, okay? And unfortunately, the majority of the patients that you're going to see don't fall into a clear-cut category, okay? The majority of the aneurysms that you're going to encounter that are found incidentally in unruptured are less than a centimeter in size, and it becomes, and the data would indicate, somewhere probably around the 4 to 6 mark, you should consider treatment for them. And also, there's a lot that's not talked about, but each patient is different too. Their psychological, financial, social factors in terms of their support, their ability to tolerate either observation or treatment is different from patient to patient, and that's something too that has to factor into that decision when you talk to patients about treatment or not. Okay, and then the last issue is for the patients that you decide to observe these aneurysms in. How often do you follow them up? You're going to do an angiogram every year, non-invasive vascular imaging every year, every 5 years. What type of imaging do you want to do? Right, and then what do you tell patients about if there should be any restrictions on their activity or lifestyle? Patients are going to ask you, their families are going to ask you, does this mean that I should stay home and not exercise at all? Does this mean that I can't work out anymore? Like should I just hibernate? Like what do I do? And the reality of it is that I generally tell my patients, even if we're observing it, like keep track of your headaches. If you're having increasing frequency or increasing intensity of headaches, especially if they're different than what you normally have, keep that in mind, let us know. Obviously, you give them the talk about if you have the worst headache of your life, if someone finds you down, don't call us, go to the hospital, things like that. But you give them some information about this. But I tell them generally to lead their normal lives. I said, I counsel everybody about quitting smoking. I think that's the single best thing you can do for your health. Certainly from an aneurysm standpoint, it's beneficial. I tell them that they need to make sure that if they have high blood pressure, that it's well controlled and well maintained. And that they need to work with their primary care doctor on that. But I encourage them basically that normal things that are considered healthy in terms of normal healthy lifestyle, exercise, working out, healthy diet, things like that, I encourage them to continue to do so. Because a lot of these patients get really scared if it's found incidentally, their PCP, everyone tells them, stop working out, don't go to the gym, stay home, don't drive, don't do anything. And that's not the message that you want to send to them. Even if you're observing it, nothing that they do, if they're working out or if they're sitting on the toilet, the aneurysm is going to rupture when it wants to rupture. It has nothing to do with what they're really doing at the time, basically. Another question you'll get asked a lot is, well, what if I have to go on anticoagulation? What if I have to go on antiplatelets and things like that? And that's harder, basically. The line that, I'm sort of comfortable with is that, being on these things is probably not going to cause the aneurysm to rupture itself, but if it does rupture, it could make hemostasis or getting coagulation an issue, and so it may be a problem at that point. Pregnancy is another question you'll get asked about. I don't have any clear answers for you about that either. I think, usually we tell them if it's, something that's stable, if you're not worried about what it looks like, then probably natural childbirth is fine. But most of the time, most OBs will probably elect to do a C-section regardless. So the interactive portion of this. So it's a 6 by 7 millimeter ACOM aneurysm, incidentally found in a guy who basically fell and hit his head and had a seizure related probably to something not related to this, basically. Would you treat? Yes, no? Yes? Okay. All right. What if I told you the guy's 85 years old? Healthy 85, pretty healthy 85. Yeah, he's independent. He lives with his daughter, but it's only because he's newly immigrated from the Philippines to the United States. Takes care of the kids, the grandkids. Pretty healthy 85-year-old. So I wanted to treat it. He does not want it treated. And so I'm going to call him back basically in 3 months and see how he's doing. But yeah, so obviously if it's a 30-year-old, it's slam dunk, you really, I wouldn't say push, but I think it makes it much more clear what you should do. But actuarial data in the United States says that for most women, probably 85 is about where your life expectancy is. For men, it's a little bit less than that. He's already sort of past it. He tells me everyone in his family lives to be about 100 years old or so he's got potentially another 15 years of lifespan. And the other quandary for him, though, is also he is uninsured, and so he doesn't qualify for Medicare, I believe, or Medicaid because of his current status. And so cost. So if I were to treat this, in his age group, I'd probably prefer to coil it over clipping it. But at the same time, aspirin, Plavix, probably have to put a stent in for something like this, and the cost of coils and whatnot. It's not an insignificant amount for the patients. And that's something that I have to say as a resident in training I never really considered, but now sort of out in private practice, patients, they don't ever want to ask up front, but it's sort of something you do have to think about as well. So 2 different ACOM aneurysms, one from the right, one from the left. They measure this one over, This one over here on the left panel measures, the neck is about 3, but the greatest dimension is about 4.2 millimeters. And then there's kind of the same thing for the one on this right panel. It's about 5 millimeters, a little under 5 millimeters. Treat or don't treat. Safe space, come on. How old? All right, so the first one is a lady who's 45 years old. So the left panel is 45, and then the right panel is someone who's 65. Treat both? Yeah, I think so too. Based on the data, it would say, the risk is probably lower, less than about 1% per year. Both of these presented as ruptured aneurysms. So there's something about ACOMs, and I don't know what it is, but all of the ruptured ACOMs I've treated either during fellowship and during training, and then the first couple I've treated is out in Alaska. They've all been less than 6-7 millimeters. So I don't know if there's something about these, or if there's something weird that happens at the smaller sizes. But ACOMs definitely make me a little bit more concerned. I'd probably be more aggressive in treating them if they're found electively. But yeah, both of these presented as both women, 145, 165, smallish ACOMs. This one is a patient I've inherited from the prior interventionist who's up there. So this started as a 3 millimeter, perfectly round PCOM aneurysm. Didn't have a daughter sac, nothing like that. It was found incidentally when the lady was in a car accident and broke her nose. And the plan initially at the time was we should probably treat this. She was fairly young at the time. I think she was about 40. And basically, they were planning on doing this electively. And between the time when it was diagnosed and she had her initial angiogram and the time that she was supposed to come in for treatment, it ruptured. And so she was treated emergently then. And because of the way, it's a little hard to tell in this shot, it's essentially a fetal origin PCA. The PCA, the neck of it basically is shared with the neck of the aneurysm, or sorry, the origin of the PCA is shared with this. It continued to grow even after coiling. And so at one point a stent was placed and packed some more coils, and it had actually remained fairly stable, it looked like, over the course of about 4 or 5 years. And then she came back for a repeat angiogram, and now the recurrent portion of it is about a little over 1 centimeter by 8 millimeters. And so she's probably realistically an MRS of about 3, not in the greatest health, but still only 55 years old. And so the question becomes, we should probably treat it, but what the best way of treating it is. So let's see. This one. If I told you it's got a daughter sac on it, it's about 1 centimeter by 5 millimeters, or 1 centimeter by 8 millimeters. Treat? Yeah, definitely. So that's it.